Good evening, everybody. My name is Patricia Hernandez. I'm going to give everybody about 1 minute because I want to be respectful of everybody's time this evening. Real quick, I'm going to give a quick introduction. As I said, my name is Patricia Hernandez, and I am part of a group. We are the Sustainable Housing Solutions, and Summit was at the end as we had it in March. So we heard a lot from our neighbors in our community and wanted to hold another training or just more of an educational kind of event to give just some more information, maybe some resources that will be able to help our community at large, and especially those that are experiencing homelessness. We have Sarah from Truman Medical Center, Sarah Kaiser. She is an LCSW. I don't know what LC stands for, so what is that?
That is licensed clinical social worker. So I've got my master's, and then I've got some other years under supervision. So basically, I can be a therapist if I so choose.
Oh, super.
Yeah.
Well, that's wonderful. And then we have Amber Bauer, and she is with the Greater Kansas City Coalition to End Homelessness. I got it. And what is your title, Amber? I actually don't know that. I'm so sorry.
You're fine. I'm the program director at the coalition. I don't have any fancy schmancy letters behind my name.
That's okay. I don't either. And I think the most important thing is that we don't all kind of, have those titles quite yet, or because otherwise, how would we learn? Real quick, if you guys have any questions, please go ahead and pop those either in the chat or in the Q&A at the bottom. That way, Marquez and I or whomever can get to those quicker than doing it over video. Again, I want to thank everybody for being here. I know it's not a pretty topic, but it's a necessary topic. And having empathy is something that I strive for, and I hope that others in the community can strive for as well. So Sarah is going to start us off. The training description a little bit. So she's Mental Health 101, an impactful street outreach training. We're going to learn about how to engage with individuals with more severe mental health concerns like schizophrenia and substance abuse disorders. You'll also learn how to have the most impact in assisting individuals living outside. Like I said, Sarah is going to start us off with people first language and why that's important with a quick overview. She said that she normally doesn't do this type of educational training in such a short amount of time. So I want to thank her so much for doing that and kind of shortening that for us so we don't get lost. So Sarah, if there's nothing else from any of the other panelists, I think we should go ahead and get started.
Great.
All right, Sarah, go ahead.
Yes. All right, everybody, I'm going to share my screen as I have been. You'll see my desktop for a second because I am not skilled enough at these things, but let me get my presentation going. All right, there we go. Oh, we are rolling ahead real quick. So a couple things, I'll just real quick, I want to introduce, I want to make sure, am I panelists, can you tell me if I'm on the right screen here? Because I have just lost all ability to view my screen.
You're good, Sarah.
Awesome, thank you.
You're welcome.
Thank you. All right, so a little bit first off, so I'm Sarah Kaiser. As Patricia mentioned, I'm a licensed clinical social worker. I am the Associate Director of Supportive Housing at Truman Medical Center. So I have been in the field for about 15 years. I've been a caseworker, a therapist, you name it, I've probably done it at some point. Outside of Truman, I teach psychopathology, which is the diagnosing class at UMKC in the Masters of Social Work program. So yes, let's talk a little bit very first off about people first language. So something that's really important that we acknowledge and do is to, we don't want to increase stigma. So one of the ways we do that is acknowledging the whole person, and the whole person is saying that my diagnosis or one of the aspects of me is only one part. So that might be saying something like, a person, an individual with schizophrenia instead of saying schizophrenic. So I ask that in the chat or as we're going along with things, asking questions, that we use that people first language. So a person with, that helps it to not make it, because somebody isn't just schizophrenic. That is not their whole world and their whole life. It's only one aspect of who they are. So, all right, I would like to get the ball rolling a little bit with, I want you guys to put in the chat, what percentage do you think, and I, just as a note with the chat, make sure you select to be able to chat with everyone, not just host and panelist as you're chatting, because I'll give you a couple of things to put in the chat about. What percentage of Americans do you think have mental illness? So I want you guys to put that in the chat real quick. Right. Got some people going. Seeing, okay. Actually, so seeing from you guys, it's actually a little bit less than what a lot of you guys have said. So it is 1 in 5 US adults experience mental illness. And so now I will say that there are numbers coming out. This is, I'm pretty sure this research is all done pre-pandemic. We do know pandemic-wise that there has been a significant increase. There's been a lot of different numbers thrown around. And when I do presentations, I try to stay focused on the most reputable research on things and not really get into too much of emerging trends yet. But what I can tell you with COVID is that we are seeing upwards and getting close to, I think people have said at some point, like 50% of somebody who could receive a clinical diagnosis. So, all right, I will, also for you guys, I will send out my slides after the fact with everything, and also with some links so you can dive into some of these infographics a little bit more. I'll also reference that 1 in 20 US adults experience a serious mental illness. I'll explain a little bit more about what that means to have a serious mental illness. But just thinking about who's here right now, we've got about 55 participants. So when you look at that, we've got about 11 people who have experienced some type of mental illness, just pure percentage wise. And then you've got 2 or 3 people that have a serious mental illness on top of that. So yeah, so you can dive in a little bit more. I will highlight real quick at the very bottom, I would like to point out the really large numbers with the LGBTQ community and those who are mixed and multiracial as well. I won't dive in entirely into why, but I think you guys can probably assume or chat a little bit in the chat about that. Typically, as society struggles with a group of individuals of people, cases of mental illness tend to rise in doing that. So, all right, what causes mental illness? So the biggest things we know is genetics. Genetics is the largest cause of mental illness. Many disorders like substance use, depression, bipolar disorder are highly linked to genetics. Trauma is also a big piece as well. So PTSD is obviously, caused, post-traumatic stress disorder is obviously caused by trauma. But we also know that there are many other disorders that are triggered from trauma as well. So if you think about it, for one person who loses a loved one, they may bounce back within a couple of months. But for someone else, it may trigger something bigger. And maybe that, maybe they're predisposed genetically to something. It also just may be, events that have happened in order. Maybe they've had like 5 events in the last year that have happened that have been really traumatic. And all of those together, have really made it hard on their brain. So I will not go super in depth on adverse childhood experiences, but it is very much worth noting on here. And so if you guys like to dive in and learn more, I highly recommend Googling ACEs or adverse childhood experiences. CDC has a little bit of a primer on that. I'll also link to that as well. But what we know is that the more adverse childhood experiences someone has, that's going to lead to more negative, can lead, I want to be very clear, can lead to more negative outcomes in adulthood. And that can be anything from chronic physical and mental health problems to substance use to even earning potential. So it has quite a large a depth to kind of what it can impact. So that is something we are learning more and more, and really seeing those childhood experiences in adulthood and having that impact long term. One thing I just really want to make sure that we don't gloss over is the effect of trauma cannot be understated. It is not necessarily as researched as well as genetics, but we do know that there's very significant amounts of trauma that have impacts far out and far reaching. One of the emerging trends I also will say that we're seeing just research wise is generational trauma. The full research isn't completely there yet, but we do know that generational trauma can be coded into genetics. And so that also can very easily then, based on what we know, can then lead to mental illness and stuff like that as well. So lastly, I will say also an area that we are researching more is epigenetics. And so those are environmental triggers that change the way the gene expresses itself. So if you want to think of this like a light switch, so maybe something happens, whatever may happen in the world, something might happen and it flips a switch, and then it, causes that, mental illness to express itself in that way. So one example you can think about is, and this isn't quite epigenetics, but it's more genetics, but somebody with substance use, if they happen to use marijuana and it happens to be laced with something, and they were already predisposed to some psychotic disorders or schizophrenia, it's likely that that could then trigger some psychosis in them, and then it could keep going rather than it may not impact somebody else in that same way. That makes sense. So, all right. So I want to take a minute and talk about stigma attached to mental health. So I want you guys in the chat to go ahead and mention some things in there. What stigma have you heard about mental illness? I'm sure everybody has heard different things. So I just want you all to take a moment and put some stuff in there while I chat. So when I think about stigma and what my experience has been in the mental health world, is that it often comes out with things like, well, if they just, took medication, or they should, and they being somebody with mental health or mental illness, if they only did X, Y, and Z. First off, we don't know, and you guys are going to hear me say this a lot, but we don't know what's best for other people. That statement of, if they just took medications, it would all be fine. We actually don't know that. There is an art and a science to a lot of psychiatric medications. There are a lot of people who, medication is extremely helpful, but there are some people that medication is not effective. And so we don't know that. People know what's best for themselves, and we really need to honor that. I want you guys to think a little bit, when you think of stigma around mental health, think about your own life. And so for those of you with kids, the one thing I really want you to think about is that very well-intentioned but unwanted parenting advice that you get. If you just did this, your kid would sleep through the night. Or if you just discipline them this way, they would stop doing that. We all know that every child, every kid is unique, and parents know what's best for their kids. So when we have statements like that, where we're saying, well, if they just, or they should, or if they only, it ends up promoting shame in people. And it's really important to reduce that, because we know if people are experiencing shame, they're less likely to seek out treatment. And also, none of us like shame. Let's just also be transparent about that. Nobody likes to feel ashamed about something. The other thing, when it comes to stigma, I really want to debunk too, is that mental health isn't scary. So we know, research has shown us that we know that individuals with mental illness are more likely to be a victim of crime than to commit a crime. All right, I have to move something real quick, you guys, I apologize. All right. Oh, and lastly, my key is just, the key to a lot of this is just being non-judgmental. So I just really want to make sure that as we think through this person first language, really not being judgmental about mental health, substance use, anything of that nature. All right. Okay, next, there we go. So severe and persistent mental illness, or serious mental illness. So I mentioned that earlier. that the stat is 1 in 20 US adults have a severe and persistent mental illness. So what is that? It's exactly as it sounds. It is severe and it's persistent. So one person may have a year or two where they experience significant depression or anxiety, then recover and do all right for most of their life. Others will have repeated episodes or experiences that are honestly never ceasing, or they may cease for a very short period of time and then pick back up again. And that's that severe and persistent mental illness. So what you can think about with this, when we think about physical health, and really if we want to think about mental health and physical health as equal, which if any of us figured this out during the pandemic, one of the things we know is that we actually value mental health more than we value physical health. I mean, how many people did you hear that were like, you know, I can't take it anymore. I'm gonna go hang out with some friends. I don't care if I'm exposed. I don't care if I have to see people. I have to hang out with people. So when you hear that and we hear that happen, that means that, you know, if I'm willing, and this is even look back to lockdown, let's ignore what's going on right now. Look back to lockdown last year, last April and May, you know, when people were at that point where they were really breaking. We value mental health pretty highly within ourselves. So you want to think about severe and persistent mental illness like having a chronic condition. So someone has a spinal cord injury or type 1 diabetes. They're always going to have to manage it. It's going to be kind of having to always manage it versus somebody breaking their arm and having to get surgery to fix it and that type of stuff. The other thing is long-term impacts of having severe and persistent mental illness. We know that poor physical health is often linked to severe and persistent mental illness. Think about it, you know, the simple way to think about it is if you're really depressed and you can't get out of bed, it's very difficult to get out of bed. It's going to be very hard to take care of yourself, take care of your eating, go to doctor's appointments, follow up on things. If your doctor, you know, recommended you know, go get lab work, it might be hard to really go get that done as well. We also know that some medications can lead to weight gain as well, which also can cause, you know, pre-metabolic syndrome as well, so kind of pre-diabetes. When you think back to that, if we value mental health over physical health a lot of people are really willing to have that side effect and try to manage it because, you know, the alternative is a very, very unhappy life, and they may not really want that. So all of that leads to then a shorter lifespan. That's 10 to 25 years less on average with somebody who has a severe and persistent mental illness. And I apologize if you guys hear my cats in the background. They are having a ball. All right. So speaking of that broken arm, the average delay between symptom onset and symptom treatment is 11 years. So I want you to imagine that broken arm. Imagine if you waited 11 years to be treated. So it's going to basically be non-functional at that point in time. That arm is really not going to be useful. It may have an infection, you know, if the skin was broken, it may have healed in a funky way. And so when you go to try to get treatment for it, it's then probably going to have to be rebroken, and it's going to take a lot more treatment in order to make that happen. So, you know, when we think about somebody who has waited a long time, and that's, again, we're saying average. That means there's a lot of people who it's longer, some people who it's shorter. So if you waited a really long time with something like trauma, it's going to take a lot more to really treat that and kind of get a hold and really manage things. All right, again, I will send all this stuff out so you guys can dive in a little bit more on your own as well. All right, so I'm going to take really two diagnoses and dive a little bit deeper on them, and that's schizophrenia and psychotic disorders, and then substance use disorders. And so with schizophrenia, because that's also the thing that most likely if you're out and about and somebody has schizophrenia or a psychotic disorder, you may notice that because they may be talking to themselves or they may be kind of responding to potentially some voices or something that they see. So I will say I'm going to refer to everything as schizophrenia. Really, the psychotic disorder realm has a lot of diagnosis, but schizophrenia is the largest one. So I will just refer to everything as that, know that it's actually broader. So two of the biggest things that really people experience when they experience schizophrenia are hallucinations and delusions. So hallucinations are things that, I apologize, you guys, my cat has a ping pong ball and he is excited. Hallucinations are things that aren't there. So that can be anything from your 5 senses. And so that can be sight, sound, smell, touch, taste. Often auditory and visual are the most common. Delusions are beliefs that aren't real. So that is, imagining, for instance, that if somebody told you, your best friend, so say your best friend is Becky, and somebody says, Becky's not your best friend. Becky's just a random person you met on the bus. That's it. You don't actually know her that way. So that's a little distorting and it's a little disconcerting to have that. When you think of hallucination, something that's really important to think about is that they are very real. It is not cartoon-like. It is actually as if, your computer sitting in front of you. It's as if somebody said, that computer isn't real or that phone isn't real. So if somebody said that to you, that's really, really going to mess with you and you're going to start to not trust the world. And really the world becomes a very, very scary place. You feel very vulnerable. It feels like, I don't know what to expect. I don't know what I can trust and what I can't trust. And so the one thing I really want you guys to take away is that if somebody's experiencing schizophrenia, it's really tough. It's really scary. There's a simulation that there's a number of simulations that can be done that I've done with students before. And the response that I consistently get from the simulation, they put on headphones, is, oh, wow, I was so concerned about my own world. I wasn't aware of anybody around me. I was just scared during that time. All right, so a couple of things on here. Age of onset, just to give you guys some few facts about it. For men, it's late teens to early 20s. For women, it's late 20s to early 30s. Each episode of psychosis or schizophrenia that's left untreated leads to symptoms getting worse in future episodes. It can, I always want to say that it can, there's nothing that is ever fact, there's always exceptions to that. But generally over time, we know the more something's left untreated, the worse outcomes it has overarching. So what are some tips? So one thing I say is other than a therapist office, and even then in a therapist office, it's not going to happen that often. You don't need to confront somebody about whether something's real or not. It just is what it is. That is their world. And so, we also all have things. If you think about anytime you have thought maybe somebody was talking behind your back, we all have things that we believe that may or may not be true. And so it's really important to understand, when we're confronted about that, that's uncomfortable for us. So we don't need to confront somebody and try to reality orientate them, is what we call it. So go along with it. If somebody says, maybe they are on your porch and they are sleeping, on your porch, and you're like, you really need to get off my porch. If they say, oh, I'm over here because someone in the bushes, there's a man in the bushes that's over there watching me, say to them, I'm so sorry. Empathize, because that is very scary if you think that somebody's watching you, and ask them, what would help you feel safe right now? Is there another place you could go that would help you feel, safe and comfortable? It can't be here, but is there somewhere else in the world or somewhere else in the city or the area? The other thing I just want to note too is that not all voices are bad. So some people really like their voices. They will keep them company, and actually they feel a lot less lonely with them. The one thing I will say is that, really, you want to, if you have somebody that you're talking to or working with, connecting them, and Amber will talk with this, to an outreach worker. But the only time somebody needs intervention from like an ambulance or going to a hospital is really if, and this is across the board with really any mental illness, is that if they're at risk of harming themselves or others. So if the voices for schizophrenia are telling them to do something harmful, like hurt themselves or someone else, then it's time to be evaluated at a hospital. Those are really the only 2 criteria for admission, is risk of harm to self or others. All right. I'm going to jump into substance use disorders. All right, so found this very nice definition from drugabuse.gov. Addiction is defined as a chronic relapsing disorder characterized by compulsive drug seeking, continued use despite harmful consequences, and long-lasting changes in the brain. It's considered both a complex brain disorder and a mental illness. Addiction is the most severe form of a full spectrum of substance use disorders and is a mental illness caused by repeated misuse misuse of substances or substances of a substance or substances. Almost 21 Americans have at least one addiction, yet only 10% receive treatment. And I will get into a little bit about that in a second. All right. One of the things that I really want, and it's really important that we understand as a community, is that we think about substance use disorder as a disease. So I mentioned earlier, genetics is a very, very large component to substance use disorders. So, many of us know that we might be able to go have a drink and one drink or two drinks and then quit and that's it. But for other people, that may not be the case. So let's take two different individuals with the exact same backgrounds. Their mothers may have both died when they were 13. Maybe they both started smoking marijuana and drinking. However, for one of them, their drinking and smoking lessened in a couple of years. And then they went on to college and kind of did some other things and just led a decent, whatever life. However, for another, they may have had genetics that predisposed them to addiction. And these habits took hold in a different way. And so maybe they started because they were like, oh, I'm 13. This is really hard right now. I'm going to cope this way. But they had the genetics there that really took them on a different path. So when you really think about that, it's really important to know that, it's not a lack of willpower. It's not a choice in this way. There may have been a choice at one point, but that choice, for a lot of us, we have made that choice at one point, but haven't had that predisposition to, excuse me, on a mispronunciation, to the addiction that then can come from that. And so it's important that we have empathy for individuals. I think there is a significantly more amount of stigma around substance use disorders than even mental illness. And so it's really important that we have empathy and we really come with non-judgment. So, it's something, when you think about substance use disorders and the stigma, we wouldn't tell someone in a wheelchair that if they just tried harder, they could walk. So that's not something that we do. So, we don't need to be telling individuals with mental illness or substance use disorders, if you just tried harder, it's more complex than that. And we need to have a better treatment approach in response to individuals. So very quickly, I'm going to go over stages of change. So stages of change, the reason I'm going over this is really just to understand that not everybody is in action stage all the time. So this is a very well-researched understanding of substance use and recovery. And so, we know, again, we'll send this out, but pre-contemplation, that's, we haven't quite identified or understood, so we may not be aware that they have a problem. Contemplation, sees the possibility of a change, but is uncertain or ambivalent about it. Determination, which is often actually referred to as preparation, committed to changing, but still considering what to do. Action, is then taking the steps toward change, and maintenance has achieved the goal and working on maintaining the change. And you can see on here that there are primary tasks associated with each one of those. So the reason I actually highlight this on here is really so you understand, say you have a relative or somebody in your life that, if you're working with them or talking to them and they are in pre-contemplation, they're not even aware that, their use of alcohol, we'll say, is an issue. You don't want to try to talk to them about, you got to go to treatment. You got to go to treatment. Really, your primary task at that point in time is raising awareness, and then you get to contemplation. I often said as a therapist, I felt like a lot of my job was helping people, because this can be applied to a multitude of things. We can look at it, think about like wanting to lose weight, pre-contemplation, contemplation. Okay, maybe I should do something to lose weight, preparation. All right, let me think about the ways I'm going to do it. Let me get the information for the gym. Action, I'm going to start going to the gym, or I'm going to, see the nutritionist or whatnot. So I often said when I was doing therapy that a lot of my job as a therapist was helping people move through the stages of change. So it was going from pre-contemplation to contemplation, then contemplation to preparation, preparation to action. It takes a long time to get to action, and people go back and forth on this all the time. So I'm sure you guys can think about things in your own lives that when you think about it, you're like, oh yeah, I can see that I'm really in, contemplation regarding this. I'm not quite in action. I will also put, I've got lots of links for you guys if you want to dive deeper on that and the individual things around the stages of change as well. All right, so one thing I also want to mention is that substance use is a mental health disorder. And we also see it as somewhat separate, which I know is convoluted, but understanding that while it is a mental health disorder, we often see other mental illnesses and substance use disorders co-occur together, but they don't always co-occur together. So it's important to know that, maybe you see somebody on the streets that, is really intoxicated. It does not mean that they have a mental illness as well. They may just have a substance use disorder. So I put this out on here. Among adults with mental illness, 18.2% have substance use disorders. Of adults with substance use disorders, 37.9% also have a mental illness as well. All right, and then among adults with co-occurring disorders, and this is, I couldn't find, and this is really the only stat on why people weren't receiving treatment. So I was like, I'll use the co-occurring disorders, but this is pretty similar, just from my experience with anybody with a substance use disorder in general. So reasons that people are not receiving treatment, almost 39% are not ready to stop using. 35% had no health insurance and could not afford the cost. 13% might cause neighbors to have a negative opinion of them. And then you go down from there, did not know where to go for treatment, had insurance, did not cover the treatment cost, no program had the treatment type. So when you really look at the top, and I will say the other piece to this that is not highlighted on here is just lack of treatment spaces available as well. We do not have enough options for treatment. It's also really important to understand that treatment looks different for everybody. Recovery looks different for every person. Sobriety isn't the only option. So we have found, and research says that we know that reducing in moderation is also very effective. More people are able to reduce their use than they are to stop using it altogether. So, one of the things, it's also really important is that people get the kind of treatment that they want. So it's not, saying that like, we're going to do a 21-day inpatient treatment. That's what you're going to do. They may not want that. Maybe they want a spiritual-based treatment. Maybe they are looking for 12 steps. Maybe somebody else is looking for something different. You've got to find the right treatment for somebody. It's never a one size fits all. So with this, I also want to talk a little bit about harm reduction. So some of you guys may have heard of things like needle exchanges. Harm reduction is basically, it's making it as safe as possible for the person who's using when they're not ready to stop using. So it's not condoning the use, it's just making it safer. It's really important to maintain that non-judgment. All right, and what that, I will say real quick, what that looks like across the board, it can be things like having safe supplies, making sure they're using in pairs, testing new batches in small doses, having overdose supplies like Narcan, and then in other countries they have like safe sites to use as well. All right, so very briefly, I'm going to touch on alcohol and meth. Alcohol and meth are the two most used substances in our area. So just basics, a lot of you have learned this, potentially somewhere along the line. Alcohol is a depressant, so people may pass out, they may get sleepy, stuff like that. Meth is a stimulant, and so imagine somebody who's on a lot of caffeine, only it's amped up way more. Imagine somebody who you're like, ooh, they look like they're on speed. That's meth. The thing to understand with meth is that typically, somebody, they might be twitching and they might be picking at themselves. It's very unpredictable. And so it's really important, if somebody's intoxicated, you don't necessarily have to approach everybody and help everybody. It's really, if they're really needing assistance, they may be seeking it out, or their friend may be seeking it out. I will say tips for engaging people who are very intoxicated. Maybe you're really worried about their well-being, or maybe, again, we'll say maybe they're on your front porch and you're needing to engage with them in some way. Be kind and gentle. Say hi, introduce yourself, ask first if they need help. If they are responsive, they're likely okay. If they're unresponsive, call 911 for an ambulance. If you need them to stop doing something, again, be kind and gentle and have compassion. You can also try to give an alternative for something. So say they're sleeping on your porch, maybe directing them to where they could go sleep for the night. So maybe it's helping them find a shelter or something of that nature. Giving an alternatives are really going to help provide that. But compassion is going to be your best friend in a lot of this. All right, so my last slide for you guys. I can't really talk about mental health and engaging with individuals with mental health, mental illness, without talking about the savior complex. And so this is something I don't know that gets talked about a whole lot. I mean, I think we've talked about, white saviorism and, in there, but in mental health world, it's a little bit different. It's very, very common. I see it a lot. I mean, I've had it in the past. Many new staff that I have also have it. It's this idea that, you really have this intrinsic ability that you really want to save somebody. And we may not use those words like, oh, I want to save them. You feel this pull, like I have to do something, like I absolutely have to do something. When in reality, people are very capable. We are all, able, we have, our right to determine our own lives. And so we really want to allow people to make their own decisions and be empowered in what they do. It's well-intentioned, but it also comes from a place of thinking that what's best for someone else and what they need. The other thing I will say is that it does have racist roots. So I'm not going to dive all the way into this, something you can really dive into, but if you think about back in the day, it often actually started in particular around religion, and thinking that people needed to save individuals, religiously, and it's kind of spiraled and morphed into a lot of different things. So again, it's that idea that I think I know what's best for somebody. And often it comes from a place of maybe we want to help people the way we weren't helped in our own lives. And so it comes from a noble place. It's just really important that we manage that, because what we can do if we don't do that is that we end up really not helping in the end. It's really important that we're partnering with people. So we may end up actually providing resources in the wrong way. So we all have a limited, finite amount of resources, as a community. So it's really important that we direct them in ways that are highly effective and are what people are wanting. So how to avoid it? Again, I've got an article that could go more in depth on this, but don't assume. Ask people what they need. Maintain boundaries. This is something I talk to our new staff about all the time. Don't work harder than someone. So say you have a relative in your life that they're maybe in that stage of contemplation, when it comes to using alcohol, for instance. If you're pushing hard for them and you're really going really hard, you're not honoring the fact that they're in charge of their own lives, and they really need to have the ability to be in control of that. It's also going to burn you out really, really, really fast. That gives us compassion fatigue, which is basically caring so much that we get fatigued by it. The other thing is just ask yourself, is my action helping them to get better, or is it making me feel better? So, all right. And with that, I'll give you guys my information there. You are more than welcome to email me any questions that you have. I mean, we can go over as well if Markeia or Patricia have any questions now, or if they'd like us to do it at the end of this too.
I think both and. So, Sarah, there's a quick question here. Someone asked if you could explain the difference between mental health and mental illness. And it says it's also a good thing to make that it is safe for you to help them.
Yes. Okay, so mental health and mental illness. So when you think of mental health is just our mental health in general. So, anytime we're resting, relaxing, we're happy, we're sad, that's going to be our mental health. Mental illness is really when we're having a disorder or we're having something that's going wrong, that maybe it's not going as well as we'd intentioned, whether it's depression or anxiety, or something like that. And it's really a diagnosable condition. And when we think of diagnosable conditions, I will say this, is that there has to have quite a bit of impairment in your life. So we've all experienced sadness and anxiety. It's really when that anxiety gets to a point where it's impacting our work or impacting our daily lives in such a way where, maybe we can't drive, because we're so anxious about, being on the road. That's when it becomes into that diagnosis of an illness. Think of it in terms of your physical body so mental health equals your physical body. And a physical illness is mental illness as well. And then what was the second part of that, Markeia? Was it how to make it safe?
Yeah, so it's a good thing to make it safe for you to help them. I think that's.
Yeah, so I think, if I understand this question, what makes it safe for you to do that? First off, is just somebody wants, it's if somebody wants help. So, I may need to lose weight, but if I don't want to lose weight, I don't necessarily want somebody to help me. But if I'm like, yeah, I'm ready to lose weight, or, I am saying, I really would like to see somebody about this, then that's really where that conversation can start. You don't want to necessarily put, our well-intentioned efforts, we really want to help everybody. I know it, I'm a helper at heart. That's why I'm a social worker. We don't want to necessarily force out our, help onto everybody unless they want it.
And I have a question here in the chat that says, when it comes to going along with a person with schizophrenia, would you also go along with them if it involves violence? In that case, would you instead try to bring them back into reality?
If it's violence, that's when you want to get them assessed at a hospital. So, if somebody's saying, I'm going to go after this person, or I'm, yes, I will say this, say they're wanting to, they're breaking up, they're at your house and they're punching windows. You don't need to, have compassion. First off, be kind, try to see if you can de-escalate the situation, first and foremost. But at that point in time, you probably then need to call EMS, call an ambulance, to assist them if you can't get them de-escalated in that. If it is violence in that arena. But no, you don't need to go along with that. All right. Anything else?
Thank you so much, Sarah. I cannot thank you seriously enough for being here and explaining so much of that to us in such a short amount of time. And I'm super happy to see folks engaging and asking questions and just wanting to understand, because we're all human. And I think somebody said in the chat that it's kind of like your mental health is a sliding scale, or it's more fluid than just your quote unquote, as people say, crazy or unstable versus being very quote unquote sane, So I think that's very important for folks to understand. We kind of all are on that level.
Absolutely.
And now we have Amber Bauer. She's going to talk to us about impactful homeless outreach, safety, who to call, when to call the police, the purpose of street outreach, and then some community resources. So Amber, if you're ready.
Yeah, can you guys see my screen now? Because I think it did the same thing with Sarah. Perfect. I see my desktop now. It freaked me out for a moment. So like Patricia said, my name's Amber and I work for the Greater Kansas City Coalition in Homelessness. Prior to working at this agency, I worked for a small nonprofit in Eastern Jackson County called Community Services League. And I did street outreach there for 6+ years. It's near and dear to my heart. In this role, I don't do as much street outreach, but it's still something that I'm overly passionate about. My family grew up in Northeast, so your neighborhood's very familiar with me as well. So I just am very honored to speak with you guys tonight and kind of just give you some basic foundation on what street outreach looks like. I tried to incorporate some of your neighborhood into it as well with some of the pictures that we've taken along the way over the years throughout Northeast. So we're just going to hit the ground running. So first and foremost, why is homeless outreach important for your community and neighborhood? So throughout the presentation, you're probably going to hear me say homeless, houseless, all of the above. I typically refer to our friends on the streets as my neighbors because they're all of our neighbors. They just live at places different than you and I do. When I went on my first outreach experience, I met a young lady named Lexi, and I told her that it was my first day doing homeless outreach. And she quite quickly corrected me and told me that she was not homeless, that she was houseless, that her house just looked different than mine. And that has really stuck with me through several years. And this is one of her pieces of artwork that she had done in her camp that first day that I met her. So I really always try to keep that at my forefront to really put that into my brain and into my narrative because they do have houses. They just look different than ours. So what is the purpose of homeless outreach? And it is to meet basic needs, build trust and rapport with individuals experiencing homelessness who do not access traditional services and connect them to housing resources and supports. I always like to tell people that the intention of homeless outreach is to get folks off the streets and into housing. So all of our engagements need to be around building that rapport to get them connected to and get them off of the streets. So that's something that I really want everyone to keep in mind, that it's that long-term goal that we're looking towards. So outreach defined is it's engaging unsheltered people in non-traditional settings. So that can be in camps, it can be in public parks, libraries, in your backyard, exit and entrance ramps onto the highway, abandoned buildings, and under bridges. It's also the job of outreach workers and volunteers to engage people at local businesses, storefronts, established organizations, such as drop-in centers, community meal locations, warming cooling centers, and other gathering sites. And it's also the efforts is to serve as the front door for unsheltered individuals to access services to address meeting their basic needs and in a pathway to permanent housing. So when we're out on the streets and when we're just walking our dogs, if we see folks, engage them. It's all about just saying hello, like Sarah said, be kind, be human, and just engage. Outreach can really be challenging. And when Sarah was talking about the stages of change, I really thought about this because at times, our neighbors aren't going to want to engage with us, and them engaging with us is not mandatory. They're not obligated to talk to us. It's just we need to let them know that we are here to help support them. So at times outreach can feel really ambiguous because of the time that it takes to actually get individuals wanting to engage and take those steps forward. It's all about how our systems failed them. It's all about how, they've been let down left and right, which we all know is true. Systematically, it's not the greatest. So we really have to base it on our rapport in our relationships and letting them know that we do care and that we are still here to provide them with that. So street outreach, what does it look like? So it's all about getting outside of the four walls of our agencies, out of our houses, out of our businesses, and engaging with those people that are experiencing homelessness, who may be disconnected and alienated from mainstream services and supports. This work is incredibly important and designed to help establish relationships, give people tools and resources, and hopefully enhance the possibility that they will access necessary services and supports that will help them move off the streets. Like I mentioned earlier, every interaction needs to be intentional. It needs to be about providing them with a tool and a resource to get them progressing forward in their journey. Throughout the slideshow, like I said, I'm just going to show some pictures of us doing our jobs. So Care Beyond the Boulevard is our street medicine team who always is on the street, hitting the pavement, providing medical and psychiatric services to our folks. And then some of us that do outreach, we're always out doing assessments, getting people on lists and connected. And we do them under bridges, we do them in their tents, we do them everywhere. And it's really, like I said, about taking the services to them. So what is the impact of outreach for our people experiencing homelessness? So over the past 2 decades, there's been documented and numerous positive outcomes. Some of the biggest ones that we see within our roles are decreasing the number of days that people are homeless and living on the streets, improved housing statuses, decreased psychiatric hospitalizations, reduced drug use, and improved physical and mental health. All of these statistics are shown, they're proven, and it's all about that relationship building and really getting that connection. So a lot of the times there's this misconception on what is outreach and what is in-reach. So in-reach is where folks go to get services who are already connected to mainstream services. So along the avenue and in the Northeast neighborhood, you guys have such a plethora and a robust amount of service providers already that so many of our houseless neighbors are getting services from. Some of them are Hope Faith, Christine's Place, Nourish KC, KCATC, Maddie Rhodes, Samuel Rogers, the Kansas City Care Clinic, Micah Ministries, and Healing House. And amongst this group, so many services can be provided. We have housing, we have medical, we have mental health, we have the crisis center, which is really working with our hospital diversion clients within the CIT officers. So within your neighborhood already, the foundation is there. It's about education and getting the resources to you guys to know where to help get these people to get the services that they need. So outreach is the most effective way to engage people not currently engaged with services. So some of the community organizers and providers that are already intact are the PATH teams from all of our local mental health agencies, which is who Sarah works with. The CORE, which is our coordinated outreach group, which is made up of several organizations which fall underneath our continuum of care. And they go out doing coordinated outreach multiple times a week, along with our CIT officers. Free Hot Soup is a volunteer-based led organization that has hundreds and thousands of members that literally hit the streets nightly to help serve our houseless neighbors, who do services and provide that support and that love and that kind intention to so many of our people living on the streets. Care Beyond the Boulevard, like I mentioned earlier, the big green bus. And they also post up at Micah Ministries every Monday night with one of their clinics, which serves over 700 meals each week. And then there are also various faith-based groups that are out hitting the streets regularly. So the process of street outreach and how we connect our neighbors to services is, first and foremost, we have to locate them. And we're going to locate those who are otherwise not being served. So location is huge. Then second of all is engaging and building that trusting relationship. It can sometimes take months for us that are doing outreach on the streets to even get a client to want to engage with us and even talk about services. Screening, what do they need? What services, what housing, what are they ready for? And it's really all about what they want and on their timeline. We may have a housing conversation with them for a year before they really want to take that first step to get there. And that is okay. They're still going to see that we're not going to give up on them and that we're always going to come back and re-follow back up. Assessing, we want to assess their physical health and their behavioral health needs, providing direct care and services as we are able, and then also referring them to those organizations and those already stand-up service providers that are there to help get them those treatment and the resources that they need. So connection to services. So in order for us to achieve the goal of ending homelessness and connecting our neighbors to housing, it's also always about the services. So outreach workers and volunteers need to be familiar with and have access to the wide range variety of mainstream and community services. So after this presentation, we're going to send out a toolkit of all types of services that you guys have in your neighborhood, just so you guys have that at your fingertips. So you really know when you're engaging with folks where you can send them. We also need to be recognized as doing the work of the sector and the community, and just not simply for the agency or the neighborhood that they live in. Folks can tell when we're just out there blowing smoke. Like, they really want to see that we're out there doing the work for the right reasons, and that we're really out there trying to help get them connected. And a lot of times what doesn't happen, hence why we're having this call right now, is the higher degree of interagency and community collaboration and awareness of what resources are already there. We as the providers really, really are appreciative of you guys as the neighbors wanting to learn and wanting to engage and really work alongside of us on getting our folks connected. So once again, thank you for taking the time to really engage in these conversations. So what we've done is we've identified 3 key people within our coordinated outreach efforts here in the Northeast neighborhood for you guys to be able to call on outreach. So Chance Doolin is one of our outreach workers. He is housed at Restart. So if you guys are ever in need of just general outreach engagement, or you have a camp that you want him to hit up, or you have people that just need to be engaged, this is his name and phone number. He's very, very happy to help you guys out. So just make sure that we give, Chance that option to do so. Then the medical attention that is non-emergent, Amber Holmes, who works for Care Beyond the Boulevard, she would be the contact to call around medical needs. And then Steve Gray works at Truman Medical Center. He's the supervisor of their PATH team. So we can give Steve a call when we have behavioral health concerns, and he can get one of his team out to help assess. So is it working? So effective street outreach interventions connect our most vulnerable and underserved neighbors with emergency services, long-term mental and physical health services, and permanent housing. Street outreach also helps to reintegrate unsheltered individuals and families experiencing homelessness into the larger community. So Sarah touched on safety standards a little bit, and some of the chat questions were around safety as well. So we always have to keep ourselves safe. So here are some tips and tricks just that we've learned along the way that really do keep us safe. So we'd never, ever, ever want to involve the police unless we have to. There will also be a document sent out afterwards that has some tips and tricks about when to call the police. When you are doing outreach or you are approaching someone, always make yourself known. Like, you are entering their space. So you always need to say, hello. When I'm doing outreach, I'm always like, homeless outreach, it's Amber from GKCCEH. I'm just here to chat with you. Just really make sure that you're making yourself known, because do you want someone walking in your house without knocking on the door? Absolutely not. Always go in pairs. It is never safe to do outreach alone. Even for those of us in the field that have been doing it for years, you always need to go in pairs. Do not approach someone when they're giving you the signs that they don't want to be approached. Always trust your gut. Use a safe, supportive stance when approaching or standing near someone. Keep distance, stand at an angle, and always maintain an escape route for yourself and the other person. You don't ever want to make someone feel trapped or intimidated. I always try to make it an effort to, if they're not on the ground, I get down on the ground too, and I talk with them rather than over them. You never want to look like you're trying to be that authoritative person. And never block entrances or exits, and leave an leave an escape route for the person experiencing homelessness. We never want them to feel trapped in their own home. Observe your surroundings and always look for booby traps. I know that can sound funny, but there are several times when we approach a camp or we're approaching someone where they've literally set up some traps to let you know that they're coming. So that's why you always just want to be very observant to your surroundings. And that's another reason why you always want to announce yourself. Do not physically touch anyone without permission. I know at times when we're talking to individuals, if they get emotional or they're crying, the first thing we want to do is hug or put our hand on, but that's really a big trigger for a lot of folks. So really remember, when you're engaging with folks, to do not give them any type of physical touch without asking. If someone is agitated, angry, or erratic, assess and get the additional help if necessary. Like Sarah spoke on earlier, if we have someone that's punching out windows or that's very violent and dangerous to themselves or someone else, that would be a time that we would need to call for assistance. Learn and utilize verbal de-escalation techniques. Always avoid power struggles and giving directives or setting limits. If someone's agitated and they don't want to engage with you, that is fine, walk away. They do not have to. I mean, we're all human, and when someone's agitating us, we get defensive as well. Maintain solid and consistent boundaries from the beginning. Never overpromise. Never say that you're going to do something that you're not going to do. Don't give them false hope and false expectations, because being let down is the path that they've always had and always feel that they're going to have. Make sure your phone is always charged and that your flashlights work and that you are dressed appropriately. Don't go traipsing through the woods with high heels on. Always make sure that you're safe and approachable and appropriate. So tips for outreach, kind of like Sarah said, always be humble, always be kind. First and foremost, just be human. Be yourself. We're all people, and people know when you're being authentic and genuine. Be comfortable outside of your comfort zone. I know that that's hard, but just put yourself in their shoes. Don't tell people that you know what they're going through or that you understand or that you've been there. Even if you have experienced homelessness, their story is different. Shine the flashlight in your face and not theirs. Little things can make a huge difference. Be responsive, not reactive. When you react, that's about you and not about them. Don't get defensive. Often it appears aggression or frustrations are directed at you. However, they are not. Take a few seconds to think before you speak. If you find yourself in certain environments that are triggering for you, walk away and do not engage. And then know your limits in your own skill set. Don't try to approach things or try to do things that you're really not comfortable with doing, because that's only going to harm you and them. I know as a outreach worker and as many faith-based groups that go out, we always like to make blessing bags or outreach bags. And this is just some of the things that we always know that our friends that are living outside need. Bottled water, meals and snacks, hygiene supplies, safer sex supplies, chapsticks, sunscreens, bug repellent, socks, underwear, first aid supplies, menstrual products, gloves, hats, scarves, and hand warmers. Obviously, some of these are seasonal based. So just really have on hand what you need in the moment of what the weather is at that time. And then it's always, we need to think and remember that it's in our hands to create a better world for all who live in it. And this is one of my most favorite pictures that I've taken while doing outreach. And it's my friend Lamont. And he always has quotes and saying on his hands. And this just one says, I am not what you think I am. I am, you are what you think I am. So like I said, I just always want people to be treated as human and with dignity and respect. And it's all about getting them connected to the housing that they deserve. So please, and thank you for your time, and always email me with any questions that you may have.
Thank you, Amber. Thank you so much. You just filled me with so much important information that I've been writing it all down. I know we've talked about a lot of it, but being able to share it with the rest of the neighbors is just phenomenal. And I can't wait to send this out to everybody. It's just such an invaluable information. So we have 2 questions. Any other tips for de-escalation or when a person is in extreme distress or overwhelmed? And that could go for either Sarah or Amber.
I think, I guess some basic things are, watching your tone of voice, watching your stance. It's really, making sure you're not in their space, in their bubble. This is some of the stuff that Amber mentioned as well, but, making sure that like you are calm. And if you are triggered, that you are tapping out. It's something that we use all the time that, if you, I always say like, have somebody else with you, supporting you and doing that. And that's why, so you can have somebody else kind of tap in and try to help calm the situation down. Compassion, a lot of just hearing somebody genuinely listen when they are really upset and they're really, overwhelmed, like truly listen to what it is that they're saying and what their frustration is and how can you address that. So if somebody, if you really, sometimes you can hear between the lines and you can say, this person's not feeling heard, overarching, or they feel like nobody cares about them. And you can really address some of that. That may also help. But tone of voice is something that is just like making sure you're warm, you're compassionate, tone of voice. And sometimes it just takes time. So, when it comes to like there's an escalation like bell curve. And so most people, like once they're up here, they can't stay up here for too long. They're going to come down and de-escalate eventually. So maintaining calm while keeping yourself safe as well. Make sure you have your distance and you're in a good spot as well. So Amber, do you have anything to add to that?
Yeah, I would just echo off the volume and the tone. I think that is a lot, and just your own like nonverbal reactions that you're not even aware that you're having. I think it's just really being self-conscious of yourself and knowing your own reaction, I think, is huge. And I think that takes time because sometimes we don't even know that we're reacting, but our facial expressions and our clenching and our body stature says it all. So just really, like I said, getting comfortable in your uncomfortable zone is huge. I'm not going to say that I didn't struggle at times doing outreach sometimes, because stuff could get agitated and escalated, and you just sometimes have to walk away. And then when you come back that next time, they really see that you're not giving up on them, and that even though you had that bad first interaction, you're going to come right back to them and try again.
And just on that, neighbors mentioned this, trust your gut. So,
Yeah.
Really, it's just very important. We talk about in the field, we talk about your gut, like we talk about it as if it's an actual skill set person knowledge base that we have, and we're respected as that. Like your gut is incredibly important. And when you get into the brain dynamics of it, like that's your amygdala, like sensing danger before you sense danger. And so it's starting your heart racing. Now, sometimes our past experiences may cause that to go off maybe unnecessarily. And so we do need to acknowledge that. And so sometimes you just want to like check the facts and like orientate yourself of like, is this really a dangerous situation, or have I just had an experience before that makes me think this is a dangerous situation? But if your gut's saying this ain't good, it's probably not good, and it's time to peace out.
Patricia, do we?
Awesome. Yeah, we have a couple of more.
Okay.
Yeah. So is means testing having to
Patricia,
services and support?
Patricia, we lost your sound for a second. They're asking if means testing, so people having to demonstrate that they're income eligible, is that a barrier in your community when trying to access services and supports?
I would say at the front door, I don't think it's a barrier, but I do know that there are some like programs that you have to have a certain income eligibility and threshold to access like dollars around housing. But all of these providers at the front door, absolutely not. It's not a barrier.
Yeah, for Truman Behavioral Health. So we've got a lot of different funding sources, but our main funding source is as a community mental health center. So we're funded as a part of the Department of Mental Health in the state of Missouri, which is ensuring access to basically all Missourians have access to mental health care. There are some guidelines. It honestly, typically, if somebody has Medicaid or if they don't have Medicaid, like we're able to, maybe they're not eligible, we're typically able to get somebody services at typically free, if not at a reduced cost.
Sarah, I would piggyback though and say that I do believe that there's a perception amongst our client population that they don't qualify for services of various kinds. And we have had a lot of instances where folks are not eligible for treatment facilities or treatment programs based on their own income or whatever their circumstances look like. And so I do think that there needs to be some broader education for the customers themselves about what services they might be entitled to.
Absolutely. You are absolutely right. Especially when it comes to substance use treatment, that is the place where like we have a lot of growing to do as a community. There is, it's just, it's hard. The funding sources are hard. We have a lot of room to grow in how we ensure that everybody has equal access, equitable access to substance use treatment.
Well, and somebody mentioned earlier, and I thought this was really astute in the chat during the time when you were talking about the stages of change, that you have to also intervene when the person is motivated to stop using. And so sometimes you have a window of, a couple of hours, and if you miss the bus, it's not happening. And so I think that timely intervention is as important as the availability of whatever that intervention looks like.
It is. And that's part of the struggle that we have currently in our community. And I would say, honestly, probably across the nation, if I'm being honest, but like really in our community in particular, is that, when somebody is ready, they are ready right then. And that can change at any moment, like Markeia said. But often the ability for appointments, the ability for treatment, all that stuff doesn't necessarily line up with the willingness and readiness. And so that's a huge, huge challenge for a lot of individuals seeking substance use treatment.
And unfortunately, I think something's happening with Patricia's sound. So I'm going to pick up where she left off until I see her face again. So we've got a question here that asks about building trusting and supportive relationships when there is high turnover of staff from burnout or for other reasons. How do you continue these relationships when a staff member has left?
So I think burnout and staff turnover is everywhere. And I think that is what's hard about building those relationships. The good thing is, and I don't know why this is, but a lot of our outreach workers within our community agencies have been around for years, and it's something that they're so passionate about. We've been lucky that those relationships and that those can continue. The 3 names that we did offer you in the slideshow, which you guys will get, are all long timers and they're not going anywhere. I will knock on wood now that I said that, because I probably just jinxed ourselves. But it's critical. And like I said, I think that there's enough of us, and I always use the term OGs, around in the community that we know enough people that we can always do that gentle handoff when there is turnover for new workers, and you work alongside that new person until that relationship is then built again. I will tell you that it's traumatic for clients and neighbors to have to retell their story to people over and over and over and over. And so that's why we are pretty intentional when we do send people out on the streets to do our outreach, because we don't want that to be a thing. We like our small core knit group that when we have questions about folks, they know who they are, they know where they're at, and they can really connect that and tell that story for them, so they don't have to continue to traumatize themselves throughout that process. Sarah, I don't know if you have anything to add.
The struggle is real, especially right now. It is, as healthcare, mental health is healthcare. Staff shortages are extreme. People are getting burnout. One of the things that's hard when you're in the helping field is when you're struggling, like a lot of us have during the pandemic, you're struggling with your own mental health, and then you're trying to help others. That can be very difficult to kind of push through, and it can get very exhausting very fast. So there has been a lot of turnover, more than even normal. Some of the ways that we try to do it is we try to have multiple relationships with individuals. So if you can have, we try to have a couple people knowing every individual, so we can have some, help within there. On a systematic level, as a leader, we try to really work not just on self-care, but like how do we embed that into our culture and our agency as well, and that we set up environment in which people are able to do that. We have workloads that are reasonable, and things like that, so it can maintain long-term. We often use self-care as just self-care your way through it. That's not always the case. We can't just self-care our way through it. We've got to also have the systems in place to support individuals that are working in the field. So, but yeah, we do warm handoffs as much as possible. That is our number one priority. We may not get everything else done when somebody's transitioning. There's other stuff that I'm like, we will deal with that later, but the warm handoff is the most important thing that can possibly happen.
Awesome. Thank you. Thank you guys so much. Can you hear me okay right now? Okay, perfect. So we have 2 more. It looks like we have a lot going on in Pendleton Heights with visible camps and a lot of pushback from neighbors over it. How can we have a conversation with some of you on how to help and what to do? There's a big neighborhood association meeting next Tuesday about this. It's all very hard to navigate. I want to go ahead and say something real quick. I'm the president of Indian Mound Neighborhood Association. We are a little bit more empathetic when it comes to our unhoused neighbors, and we recognize that that's the case. I would be happy to come on Tuesday and do some chatting. I can't promise that I will be able to sway anybody's mind, as a lot of folks kind of have they're kind of set in their own ways. And I respect that, and I understand that. That's why we were holding something like this in hopes that folks would join us and just kind of listen. We all have things that we're struggling with. It's just not all visible. We don't get to have it next to the highway like some of our unhoused neighbors. We get the privilege to do it in our own homes. So I don't want folks to forget about that either. Amber or Sarah, do you guys have any suggestions?
I'll just say, when it comes to hard conversations with individuals who have very different viewpoints, what I have found around mental health in particular, but really when it comes to anything in the social service field or individuals who are having a hard time, is just really helping to build the empathy. One of the ways you can do that, and why I kind of leaned into this a bit today, is through statistics. So sometimes people understanding that, and I have a lot of stats and websites you can go to get more stats, can also really help. Facts, things like that can help people to understand the magnitude and take some of the opinion and the feeling out of it. That can be very, very hard. I am on the board of my HOA, and I live downtown, and it is hard. It is hard conversations when somebody is, stuck in their viewpoint that, they're choosing this, why are they doing this and whatnot. The other thing I will add is I add real stories. So I give real stories of real individuals to help them maybe start to see it from a different way. It's not that much different, unfortunately, than having a lot of the political discussions that a lot of people have had. It's similar. It's a lot of hard conversations in there, but building empathy is the biggest thing I have found to be the most helpful.
And I agree. I mean, I'm going to bounce off both of them. I mean, I'm always willing to talk. So I think that question was from Courtney. You have my information. If you want to call and email, and we can chat prior to next Tuesday. But I think it's just sharing stories. And I always tell people that are new in this field, like, if you've never done outreach and you've never gone and actually talked to someone that is living on the streets experiencing homelessness, you're missing out, because some of the folks that I've met during outreach have really enriched my lives in ways that I can't tell you. I've never had to live on the streets. I've never not known where I'm going to lay my head or what I'm going to eat the next day, and just really seeing their resiliency and the amount of passion and desire that they have to live and survive every day will really make you take that step back and not even imagine walking in their shoes for a day. So I think it's really looking at it from a different lens of, I don't want them here, to how can I get them to where they need to be, because they deserve it just like you do.
Absolutely. Well said, Amber.
Yes, thank you. I agree. Okay, we have one more. I understand that sympathy and empathy are different things, and sometimes it's hard to differentiate the feelings you want to convey and how it is perceived. Is there some advice or resources for something like that?
Well, I'm just rereading this to make sure I understand. So I understand that sympathy and empathy are different things, and sometimes it's hard to differentiate the feelings. So as far as, when it comes to conveying empathy, is really just listening. So really, and empathy is the point where we can understand somebody else's shoes. We haven't necessarily been in them, but we can understand them. And so it's really, what I have found is the best advice for doing that is, when it comes to building your empathy, YouTube, for the class that I teach, I use YouTube all the time. I actually give a lot of simulation videos for my students because it helps them to really build that empathy, to really know. And I will send a few of those simulations out for you guys as well. But also just when you are communicating with somebody, it's really, it's listening. Listening is the best way that I have found that you can do it.
She was eloquently spoken about that topic, so I'm going to leave that one right there.
Thank you. Thank you so much. Someone just said in the chat, I always say to homeowner in a polite way that you are quite possibly one pink slip away from being homeless. And I mean, aren't we all kind of just a couple $100 away from not having a traditional roof over our heads? So, yep. I wanted to thank Markea, Sarah and Amber for doing this. I just thank you so, so much. Yes. So our partners, myself, we have Sarah Kaiser with Truman, Amber Bauer with Greater Kansas City Coalition and Homelessness. It looks like we had Scott Wagner on the call as well with Maddie Rose and Neat over here in Northeast. We also have Wick Thomas on as well, who is in our group of for the Sustainable Housing Solutions. We also, Anne wasn't able to join us today, but she has been so big within the city, Dr. Williamson, trying to just do anything that she can. And I just thank her so much. She doesn't even live in the city, and she still travels here so much to help our group and the city. And then as well, we have Aaron Crossley and Robbie, who are both, they both worked at Truman Medical Center, and they have just been so instrumental in just getting so much done. And then, of course, our fearless leader, Representative Ingrid Burnett. I think she was on the call as well this evening. And I wouldn't be here without her. So thank you so much. A big, huge shout out to Truman Medical Center, Behavioral Health, Greater Kansas City Coalition and Homelessness. I'm going to get that one day. And of course, the historic Northeast community as a whole. Thank you, everybody, for participating. We're going to try and get this video out to everybody as well as the decks, because I know this information is just so valuable. Markeia, would you like to say anything?
A couple people from our global community. So we've got a couple of folks that are from outside of the United States who have joined us. And I have no earthly idea how you found us, but we're so grateful that you're here. And then I got the perception from a couple of people, Toronto. So somebody leaked on the Facebook Canada and Facebook Australia that we were doing this, which is really cool. Those are two parts of the world that we study a lot. We look at your homeless response. You're doing some really cool and significant things that we reference when we're thinking about how to be more intentional about the way that we do things. So it's really an honor to have you here, and we'd love to have future conversations.
And I was going to add, I know that there are some providers on the line as well. And if you want to send me any of your agencies, or even if you're a neighborhood, a church, any of your information, send that to my email. And then when we send out the toolkit, I don't know why I'm calling it that, but that's what I'm calling it. We can add your guys' literature and stuff as well. We would love to have all of the knowledge as possible to share with all of you.
So what time is it in Australia right now? Is it the middle of the night or? I got to look that up. You got up early or stayed up late, I think.
And from California, it looks like too. Wow, I just can't believe this. Thank you, everybody, so much for joining us today. Oh, 11 a.m. Oh, okay, that's not too shabby. I hope everybody, in Illinois, wow. Well, thank you, everybody. Thank you so much for joining us. 8 p.m. in Texas. This is awesome. Bye, Jordan. Vancouver. Have a good night, everybody. Thank you again.
Thanks, guys.